Hello, everyone. Welcome to this month's NY Cannabis Grand Rounds, a monthly educational webinar designed to advance knowledge and provide healthcare professionals, researchers, and educators with the latest evidence-based insights on medical cannabis. My name is Sang Choi. I'm a research scientist at the Office of Cannabis Management and your moderator for today. So in honor of Cancer Survivors Month, we are honored to host Dr. Dylan Zylla today, who will be presenting Holy Smokes, providing cutting-edge cannabis research and education to patients with cancer. But before I start, I will read a brief disclaimer to ensure clarity on the content and scope of our discussion today. The disclaimer is the views and opinions expressed in this live event are those of the speakers and do not necessarily reflect the views or positions of the Office of Cannabis Management. The Office of Cannabis Management makes no claims, promises, or guarantees about the accuracy, completeness, or adequacy of the contents and expressly disclaims liability of the opinions expressed. The appearance of these speakers is for the information and convenience of the public and does not constitute endorsement, recommendation, or favoring by the Office of Cannabis Management. So I'd like to take a moment to introduce you to Dr. Dylan Zylla. He is a practicing medical oncologist and is the medical director of HealthPartners Cancer Research Center. He serves as the expert in adult medicine on the Minnesota Office of Medical Cannabis Advisory Council. Over the past 10 years, he has developed relationships with local and national experts in the field of cannabis research and has become a leader in studying the impact of cannabis on patients with cancer. His team has successfully conducted several randomized clinical trials using the Minnesota State Medical Program. And in 2021, Dr. Zylla launched the Cannabis and Cancer Research and Education called CanCare clinic to educate patients interested in cannabis use through one-on-one video consultation with an oncology advanced practice clinician. So please join me today and welcome Dr. Zylla.
Thank you, Sang, and thank you for the invite on this timely event. I don't have any disclosures to present other than this is probably AI generated. Here's my objectives. I'll let you read through them. Basically, just reviewing some of the studies, mostly in patients with cancer, although there's a lot of overlap, of course, with that. Understanding a little bit about our Minnesota medical cannabis program, which has evolved over the decade or so that it's been in existence, and then talking a lot about what we've done and some of the opportunities, things that we present our patients. So I started with the patient case, a little lengthy here, but basically a patient with newly diagnosed metastatic pancreatic cancer. He's having lots of symptoms. He's on chemotherapy. You can see he's on opioids and antiemetics and things for bowel medications, and basically comes to his oncologist and says, hey, I've heard about cannabis. Could this be something for me? And what do we tell these kind of patients? And so, this is a growing issue, right? Patients are expressing interest in how to use cannabis, but most clinicians, oncologists in particular, just do not feel well prepared to discuss the risks and benefits with those patients. And these are the questions that I think we're going to try to answer today. As you can see, what are they using? Who's guiding them? Why do patients want to use? When do we need to worry? And then again, I'm going to touch at that last part of the talk about all the things that we've been doing here at HealthPartners. This was a nice overview slide, a systematic review essentially of what we put together a couple of years ago. It's actually 2019, so probably warrants being updated, but it kind of went through a lot of these questions. And this is a figure from that paper. So again, asking some of these questions at least 6 years ago, and some of this data obviously has been updated. But I'll go through first. Who's using it? Well, again, cannabis, ancient medicine, right? 2,500 years, patients were buried with their medical cannabis. I think even in the early 1900s, this was an over-the-counter medication. As you can see, this one-night cough syrup certainly going to do the trick with alcohol, cannabis, and morphine in it. And obviously that did not continue, but circa 2018, we started to see other products hit the market with things like Munchie Way and all sorts of creative, clever names for medical cannabis products. This is not a talk about the history of cannabis in the U.S., but I think it is a very interesting history. What's kind of missing on this figure, though, I think in 1970 is when cannabis was labeled a Schedule I drug, and that really sort of halted a lot of the efforts and the research and obviously legal aspects of cannabis. And again, since 2020, so much has happened, right? This is a continued green wave, as we say, is spreading. Really, most states have some type of cannabis program on the book. More and more are becoming adult use or recreational use. Minnesota is actually one of them as of a year or so ago. The Minnesota Medical Cannabis Program, when it started, was in about 2015. These were the original indications, as you see above. And for cancer, it was cancer that had to be with pain, nausea, vomiting, or cachexia or severe wasting. So one of those three symptoms along with their cancer. And then each year there's been added indications added to that. And you can see over these years, there's just been some real explosion in the use. So as of about 2024, about 50,000 patients approved in the Minnesota registry. There's been some key inflection points. Some of it's just about terminology, how we labeled intractable pain. Then it was labeled more chronic pain, and that sort of was a big inflection point. And then the latest big inflection point was in 2022, when instead of having extraction products only, we allowed whole flower, which made it cheaper and I think a lot more products available for patients. So it's been a big growth. You can also see in Minnesota's program, it's not all just the same patients. It's a growth in new patients as well, as evident by the higher graphs on the right. For the indications of patients in the program, again, I'm interested in cancer. Really, only 5%. I'm surprised by that. It's only about 5% of patients, despite the number of patients with cancer that are enrolled. Most patients are for pain, chronic pain or intractable pain, and then PTSD is quite a close second there. In the patients with cancer, this is sort of their age breakdown. Again, not surprisingly, an older group, right? So 75% of patients are going to be older than 50. That's just the demographics of our cancer population. A study by Pergam you'll see this in a couple other slides, probably one of the most often cited slides or papers, really well done prevalence study kind of showing that about a quarter of patients with cancer are actively using cannabis at any given time. It ranges a little bit by age, so maybe a little less as you get over 70. Again, but this is 2017, and I think these rates even themselves may be changing. We were able to participate in a very kind of an updated to that survey, an updated study that I did with the University of Minnesota, as well as 12 other NCI designated cancer centers across the country. It was published. The results of our combined work is published in this paper. What's on the right is actually Minnesota. So our state and our respondents, you can see some of the more updated data. Again, 40% using cannabis at some point, even prior to their diagnosis. Here's again the 1 in 5, 1 in 4, 1 in 5 saying they've used cannabis since. And it ranges cancers and it ranges stages. It's not all stage 4 patients. In fact, actually, it's kind of a surprise that it's not as many stage 4 patients as I might expect. We see the similar sort of data in our own clinic. So again, we're going to talk later on our cannabis education clinic at HealthPartners that went live around 2021. We've been in existence about 4 years and seen over 650 patients in that time. You can see the demographics there. Again, we actually welcome patients who have no knowledge and no prior experience with cannabis. And you can see about 40% are not currently using cannabis. And again, wanting that information. In our data, it's about 50% that have stage 4 cancer. So who's guiding them? That's who's guiding them. Well, here's the problem. Again, 70%, if you look at this program study, again, they looked at how 70% of patients were interested in knowing more about cannabis. And most of them certainly want it to come from their cancer care team. The problem is only about 10% get it from somebody in their trusted cancer care team. Most of them are getting it from information from friends, family, the internet. That's what those graphs are sort of showing. And again, in this more recent era of data, 72% very comfortable discussing cannabis with their oncology provider. The problem is we're just not having those discussions a lot. And again, not often are those being brought up. But I will say, I think patients are bringing that more and more, or their families. Again, a little bit older data, but oncologists specifically don't really feel prepared, yet they're having these conversations, right? So 8% have a conversation, 50% almost recommend it, yet only 30% actually feel knowledgeable to discuss the pros and cons of that. So if you just take a snapshot view of, there's about 24,000 Minnesota healthcare providers. And in order to certify somebody in the Minnesota program, you have to register with the state program. And only about 10% of all healthcare providers are even registered to be able to certify a patient in the Minnesota program for the medical program. It's really easy. It takes 30 seconds. This is all you have to enter to certify somebody is what is their demographics and what indication are you certifying them for. So what products? So this is another, really tough topic because again, cannabis is not one medicine. It's not one product. There are thousands, probably many, many thousands of products out there. And that's a big issue. We could take a step back first and say, well, let's talk a little bit about what is THC? How much is in an average joint? This was kind of a fun New York Times article from a while back. And if you look at it, it's actually evolved too. In a typical joint that's been seized by the DEA, over the years, it used to be about 8%. Now it's probably double that, 16%. So you can do some simple, ninth grade math and say, well, if you have the grams or milligrams of a joint, and the percentage of THC in it, you can calculate how much milligrams of THC is in that product. Again, lower strain potency things, 25 milligrams could be up to 50 milligrams in a joint in today's era. So it's not the same joints that maybe our parents or grandparents were smoking in the 70s. This was a figure from that review article. It's a little bit complicated. I'm just going to go through it very high level just to point out that there are different types of cannabis products. There are some prescription products, as you can see here. They are not used very commonly. Dronabinol, Nabilone, synthetic products don't have CBD to kind of combat and sort of negate some of the high, not very well tolerated, and really not very utilized at all. Nabiximols is an interesting drug. It's a refined product, really not available in the US. I think it is available in Canada and other countries. And then there's the drug called Epidiolex, which is a pure CBD product, again, used for seizures and refractory pediatric seizure disorders. Most of the Minnesota products and most extraction products or state products, I think, fall into this category. And then, of course, there's whole flower, which has been, more universal. So I might skip over this. This just talks a little bit about the products available. Initially, over time, it has changed a lot, too. As I mentioned, we went to whole flower a while back. There's been some changes in out-of-pocket expenses, which actually are for the better. We used to have a $200 enrollment fee just to be in Minnesota's program. I don't know what New York's is or if there is a fee to be part of New York's. But again, it still was expensive. Patients, this is not covered by insurance. And, those who are using cannabis multiple times may end up spending a lot of money per month. Again, just an example of the plethora of products out there. You can do more math if you want to calculate whole flower and the cost of that, the different creative names that people have. I don't know where they come up with them, but they are quite creative. And again, this is more where we stick to when we talk to patients. We usually stick to tablets and liquids and vaporizers because they're defined doses, and we can use that more medically to say, hey, we want you to take 5 milligrams or 10 milligrams of this product. Might skip over this. Is just kind of what patients use in Minnesota. So why do patients use? Well, again, that's also one that we touched on when we looked at all the summary of trials that have been done in cancer. And again, not surprisingly, you see a number of studies, really pain, of course, nausea, vomiting, anorexia, cachexia. These are all the studies that we put together in that systematic review. And you can see there are a number of randomized controlled trials. There's some double blind. There's even some placebo trials, not many. There's also, actually, before I get to the other types of trials, this was a recent study, actually a really well done study, I thought. It was done in, presented last year, or published last year, in really kind of current era. This was a study of preventive oral extracted product. I think it was a 1-to-1, 2.5 milligram capsule, taken 3 times a day for the 5 days or so around their initial chemo. These are patients that had had trouble with chemo in a prior cycle. It was placebo controlled. It was, again, using current things that we have for controlling good nausea, steroids, and all of our great, agents we give to people. What I think is striking, and this is where I think we're struggling with the field of how to advance it, is you get a really good study like this, actually shows some good data. The problem is it took 6 years to accrue 47 patients. That's too long to get, things moving in a good direction. By the way, the results were kind of promising that cannabis did actually help with preventing some of that chemo-induced nausea and vomiting. So that's the problem. Here's, again, other studies. There's some randomized studies, but there's also been large observational studies. We actually did one of those. The last one here was a study I did with our Minnesota State Department, and this is some of the data that we published out of that. Again, what you can see here is some of those common symptoms. are basically changing. So after 4 months, their average numbers are changing, shifting lower. These are all statistically significant and really good data. The problem is how this data was collected. And so there is some bias in here. In Minnesota, anytime a patient purchases a new cannabis product, they have to fill out one of these surveys, right? A 0 to 10 scale question about their symptoms. And so you're having some inherent bias about if patients are using that, they're still using, they're still purchasing, so they probably are getting some benefit, right? And so what we did is we tried to adjust for that by looking at the data a little bit differently. And what we said is, all right, let's take every patient that ever got certified. Let's look at their baseline scores on these various symptoms. And you can see cancer patients are very highly symptomatic across all those symptoms. And then we said, we want to make sure that patients are having at least a 30% or more improvement in that score over the first 4 months of their first purchase. We included everybody who did not make another purchase in the denominator. So that's why the rates look a little bit lower, but you're still seeing 40, 50, sometimes percent of patients having some, I would say, clinically meaningful changes in those scores and those patient-reported outcomes. So again, similar studies, similar data has been looked at in Israel. They've done a lot of work with medical cannabis or with cannabis in general. They have a big registry too. This was their registry. What I liked about theirs, similar sort of pain shifts, as you can see. What I also like, though, is they looked at opioids and pain medicines, and you can see some of the decrease in dosages there, which is pretty rare for especially our stage 4 patients to go down on opioids. Why else might patients be using cannabis? Well, there is this question about, could cannabis treat the cancer? Again, back to that very well done study survey in Pergam, about 1 in 4 believe that cannabis could help treat their cancer. And as many of you know, this is all over the internet, right? There are books, there are Netflix documentaries, there are just all sorts of things. This thing called Rick Simpson's oil, probably people have heard of. Again, the data that backs it up is very weak. It mostly comes from in vitro and sometimes animal model if you're lucky. But there rarely are very few studies in clinical patients looking at this particular topic. I actually just yesterday pulled clinicaltrials.gov and said there's only 5 studies that are interventional type studies. Only 2 focus on cancer control, and I think it's those top 2. And I actually connected with the Aristocrat team. They're out of the UK, looking at a study with glioblastoma, and then apparently another study I wasn't aware of looking at hepatocellular carcinoma. The rest of them are symptoms, and I will to state that you can see ours at the bottom, actually an interventional study in medical pancreatic cancer patients, which I'll touch on in just a second. So again, where does some of this come from and why do these claims get made? Well, there are case reports. They're not, always the best of data quality, but you get things like this where you got a patient with new diagnosis of lung cancer and, a year goes by and they tell their provider, well, no, I haven't been taking any chemo, no surgery, no radiation. And they see a scan that looks so much better. And they ask them, what were you taking? Well, I started CBD, right? So that was kind of a striking case report. I actually kind of thought that was a good case report. The problem is we looked at all of the case reports that were been done. We published this a couple of years ago and we said, well, we wanted to kind of critique them and analyze them. And we realized not many of them actually had much validity to them. And they were very weakly done, mostly because they don't substantiate the data. Sometimes they were using circulating tumor cells, which are really not a reliable measure, things like that. And they don't really talk about the dosing or what cannabis was used. Most of them, if they did, they were using CBD. So that was interesting. On this topic, though, and this is certainly a little plug for my own research, we have a study going on right now. It's an IRB-approved study. It's called the CATA survey. You can see the language. This is what patients see if they click on this link. And basically what it does is it has a 4-question screener question to say, are you using cannabis? Do you have cancer? Are you using cannabis? And do you feel like cannabis has helped to treat or control or shrink your cancer? And if they do answer yes to those questions, they're provided an informed consent form where we go through basically wanting to connect with them, learn a little bit more from them, actually get medical records from them to analyze and put into a larger case series. So anybody who wants to share that link with others, either in research or patient communities, certainly welcome to do that. All right, so when do we need to worry about cannabis use? Well, I'm actually a pretty big believer it's a fairly safe medicine, a safe product. Again, I deal with every day of providing toxic chemotherapies to people. And if I dose it wrong, I might kill them. And cannabis is quite the opposite. I think if you start low, go slow, I think there's a very good safety profile that there is not the opioid risk of killing people with decreasing respiratory centers. It's basically that they get sleepy and they get tired. We looked at reports in the state program, in our Minnesota state program, and again, about 11% of patients reported any side effect in the first 4 months. Most of those were mild, and you can see them listed here on the right. There are some other interactions. I'm going to touch on immunotherapy in a second. Certainly people with schizophrenia, certainly cardiovascular disorders we worry about. Some drug interactions, certainly warfarin and other things that interact through the liver metabolism, I think need to be careful with. One little pearl of how to deal with that is I often take things like Epidiolex, or I might take not nabiximols, dronabinol, these THC and CBD products. I'll put those in like a drug interaction checker if I'm kind of concerned about something, because again, that's THC and CBD, and then you can pick your drug of choice in any kind of drug interaction checker and see if there's a problem. Again, some just general things. Again, we use this as guidance. Again, thankfully, we don't treat pediatric patients. Pediatric kids may be a whole nother topic, but these are some of the things that I would be careful with. Some of the best data I think came from that nabiximol studies, and we were actually part of one of the sites that did that study. Again, placebo-controlled, very large studies, 200 patients, and again, you can see somnolence and dizziness probably the most commonly reported side effect. Okay, I mentioned immunotherapy a minute ago. Immunotherapy, for those who don't know, in cancer, it is practice changing. It is life changing for some people. It is basically, we are trying to rev up and make your immune system smarter to find the cancer rather than just give people toxic drugs that kill cancer. And in some situations, melanoma, kidney cancer, lung cancer, others, it is remarkably effective. There is an issue, though, in that some of these older studies, and these were retrospective studies, these were not really well done, in my opinion, studies, suggested that patients may have lower response rates if they were a cannabis user and using, let's say, nivolumab, a common immunotherapy at the time. And the thought is that cannabis has anti-inflammatory properties, and that could potentially negate the impact of immunotherapy. That would be very, very bad, right, if that happens. There was another study, kind of similar study, retrospective, looking at this, and they actually looked at some survival issues, and they said, well, maybe patients were, having worse progression-free survival and worse overall survival. Again, big deal. This got a lot of headlines. Actually, NCI and one of the grants that I went after cited this study, even though that was the only data that's out there. And I was kind of shocked by that, partly because this study really didn't control for things like how many patients of those different groups had brain metastasis or liver metastasis, things that mattered greatly in survival, and probably things that increase pain levels a bit more. And I think there's obviously an association with pain. Finally, somebody came around and did a study that was a little more controlled and structured, looking specifically at only lung cancer patients. All of it looked very similar. And lo and behold, didn't see a ton of difference there, although there still is this little bit of a survival difference potentially pending out there. Excuse me. And we've touched on this a little bit ourselves. We actually published this article last year, maybe this year, I guess it was published this year, just kind of an overall review of what cannabis does to the immune system. And we did this sort of outside of just cancer. So if you wanted to look at that, basically we were trying to figure out, is there other studies, clinical studies, not lab studies, but clinical studies where we've seen changes in immune scores or parameters. And the bottom line is we didn't really see a lot of things change there. This is a separate study. It's actually only published in abstract, but we're hoping to get this published really soon, where we looked at some real world use from cannabis dispensary data, and we looked at claims data and basically showed there was really no difference in the time to progression or the real world time to progression in patients, as long as you match them perfectly to the stage, to brain metastasis, and especially to opioid use. And I actually think in some of those older data, I think some of that comes with patients were on more opioids. And I think it's the opioids that probably were the trigger that maybe made either the lack of response to the immunotherapy and potentially survival. So that's another topic we can broach another time. So that's a really quick overview of sort of what some patients need to know, what patients may ask about. Obviously, most clinicians aren't going to go through all that with them in a 2-minute conversation. And so I'm going to switch gears now a little bit to just talking about what research are we doing, how are we kind of trying to advance the field forward. And I'm going to walk you through essentially 13-year now journey of mine in cannabis research. So a little bit of a funny story. I started doing this in 2012. I was the PI, the principal investigator of our site in Minnesota for this study, this nabiximols study in advanced cancer patients with chronic pain. I'm not going to get into the details of the study. It was a negative study. I think a big reason why is the patient population that they chose and how they chose to kind of find them. That's, again, not time for this discussion. But the funny story is this: it was one of my first studies being a PI. And I remember meeting with the DEA agent with his gun in tow saying, all right, Dr. Zylla, you got to tell us where you're locking this up and what's going to happen and how it's going to be, monitored, because I don't want to send you to jail. And I was like, whoa, this is kind of intense. I didn't realize research was so intense and exciting. And luckily, the study went fine and nobody went to jail. And I still practice medicine and I still do research. But it kind of got me into the field of research. And a couple of years later is when Minnesota went with their medical cannabis program. And that's where I got some partners. You can see some of these partners actually have New York ties. Vireo, Dr. Dahmer is actually no longer at Vireo's out at University of Arizona, was a big player in kind of connecting me with people across the country. A lot of these people, obviously, in Minnesota. Northwell Health, though, I think Diana Martins-Welsh, a palliative care doctor, and Edith Burns at Northwell have had some collaboration with as well. And really, I think it does take a village to kind of keep this journey going in terms of doing good cannabis research. And so that work group has essentially set the stage for a lot of the things that I've already talked about. Again, papers that we've written, doing some stuff with the State Department. Actually, one of our most important works, I think, is in 2018. And we launched this randomized clinical trial, which now has been sort of the example that we use of how to do research in this space. And we've done similar studies with it. And so essentially what it was is it was a pilot study, randomized controlled trial of early versus delayed cannabis, in cannabis naive patients. And what we were trying to essentially show is, can we do this kind of work? Not so much could we show major data and outcomes, but the first study, that what we call our CAN-CAN study, was just this. It was advanced cancer patients. They had to be on opioids. The cannabis was provided. So the 2 medical cannabis dispensaries in our state provided the cannabis. That was nice because we didn't have to worry about, well, did they use enough of it or how much did they need to get for that symptom control? And then again, we're randomized, as you see. And we collected data about their medications and symptoms and different surveys. And then again, after the 3 months in this study, 3 months, the patients in the delayed group got to go on the cannabis as well and use it there. So again, basically showing high interest in the study. We enrolled 36% of all eligible patients. Most studies, it's about 5% of patients who are eligible end up going on trial. So key point is give them free cannabis. They'll likely sign up for your study. I'm going to skip over this. You can read the paper if you want to look at some of the preliminary data we had in it. I already mentioned this sort of overview study. That was what I've presented here, the CATA survey type work, and then our clinic. So let's talk about our clinic in 2021. We kind of realized we started to know what we were doing. We were doing some studies. We were doing, some work in this field, starting to see patients ask us more directly, even seek us out a little bit for information. And we decided to create a clinic. And so we have this clinic we call CanCare, Cannabis and Cancer Research and Education. It's really for 2 patients, either patients with cancer who want to know something about using medical cannabis, or even those who are using it but want to know how to maybe maximize it in a different way. These are the things we offer them. We do one-on-one education. This is done through a video visit with a nurse practitioner. It is essentially a symptom management visit. So it's built to insurance, and our nurse practitioners do that. Obviously, the medical cannabis is on the patient to get approved or to pay for. And we also offer, if we have research studies like the couple of ones I mentioned, that we offer those. We'll talk about those with patients. Here's an article. We present this in an Oncology Issues journal. There's a link there if you want to know more about how the clinic was created up front. A little bit more about the clinic there too, if you have questions about it. But it's, again, very easy to get into. We certainly welcome patients. One of the things we've done in the clinic is provided some dosing guidelines and documents. And again, very simple stuff, but this is sort of what we talk about in those consultations. The figure on the right, actually kind of funny. I was just in Colorado, and the minute you leave the Denver airport, this is the sign that you see on the line. And I actually thought it was pretty good. It comes from the Department of, I think the Public Health Department of Colorado. Start low, go slow. Don't overdo it with edibles, right? Good advice. It's kind of the advice we give to our patients too. too. So at least Colorado is doing some good public health awareness. This is sort of our dosing guidance in a little more detailed fashion. Again, there's no perfect dosing guidance, but again, it's something to hand patients. It's something that patients can use. And again, we think it's a pretty safe way to get things titrated. Again, more work in the last couple of years. One of the other ones that was this Canaroma study. So I mentioned how we used our CAN study as a jumping off point of doing randomized trials. Well, I worked with my friends at the University of Minnesota, some breast oncologist, Dr. Blaze there, and we did a topical cannabis study for women who have aromatase inhibitor musculoskeletal symptoms, which is basically they get really bad joint pain, tightness, stiffness. Oftentimes it's in their hands and wrists. So we did a study, basically a randomized, also crossover study. This was not a early delayed, but it was randomized to high THC or high CBD. And again, just a 2-week study. Then they could choose which they wanted to go on after that. And interestingly, I mean, we're actually, this paper is under review right now, but this was one of the figures we put together. And again, this is a score, so pain score, change in pain score from baseline. So only 2 patients actually had higher pain scores. Again, small study, not a lot of patients there, but both the CBD and the THC creams or balms did seem to have some benefit to them. So again, we're hoping to get that published. I mentioned the review article. And then again, this is a current study that we're really excited about. This is kind of like, now that we've got our feet wet, now that we know what we're doing, this was a study, the CAN study, essentially version 2. So it's looking at newly diagnosed patients with advanced pancreatic cancer. So a bad cancer, lots of pain, lots of nausea, lots of cachexia and anorexia. And basically we said, look, that from the time you are diagnosed, we think you should be on cannabis, right? Those are the early cannabis. Everybody had to start chemotherapy. So again, standardizing the groups. And again, this time we just did 8 weeks, but then that delayed cannabis group could get cannabis after 8 weeks. So they served as kind of our control group for those first 8 weeks and could do everything else, palliative care and opioids and whatever. Both groups could do all they wanted. And we just presented this article. We just published this abstract, and I'm actually presenting it in 2 weeks at the International Cannabinoid Research Society meeting. That's in lovely Bloomington, Indiana. So if you want to hear more about that study, you can tune in there. But this is some of the initial data we have, again, just over the first couple of times. And I think there's some promising things there, at least in the early symptom control. Again, opioid use, there's some changes there that I think are quite intriguing about lowering the opioid use, and patients do not want to be on opioids. So I think that could be a potential win down the road. Again, that's a small study, only 32 patients. We need to do bigger studies, and we need more funding to do that. We'll touch on that in a second too. Last study, actually 2 more studies, and then we'll touch on another current study we have going on right now is a cannabis lab study. Very simple, basically same kind of thing. Get patients who are cannabis naive, check their plasma cannabinoid concentrations at baseline, and then 2 and 4 weeks after they start cannabis, and see, if there's, what we're trying to see is, what is the dose level relationship to THC and CBD, and also how does that tie in potentially with symptom changes? So again, maybe it's not an exact dose that somebody needs to take of, let's say, THC at night, but maybe it's a certain drug level that they need to get in to their system. So I think that's taking it kind of to that next level. We're excited about that. And then last but not least, again, another really exciting study, I think, that just launched just a matter of weeks ago. And we're starting it with just our patients with within our cannabis clinic. But essentially, it's an app-based registry. So what we have is this app platform called Ontraka, which is available and patients can use it right now. But we've partnered with Ontraka to create it more of a researchy kind of base. So we have validated symptom questionnaires built in that the patients get every few weeks. We ask some questions about their medications, again, opioid medications, antiemetics, other things. And then what's really nice is, again, all those dosing guidelines and things that we've been doing and working on to educate our patients, they're all in the palm of their hand too for the app. What we hope to do, again, stay tuned, is once we make sure this is working the way we want it to, this is an app, this is a registry that could go national, and anybody anywhere could use it. Patients, I think, could find value in it. We might have to do some tweaking because, again, it's a little Minnesota specific right now, at least on the education side of it. But the data we collect is very, very quality data, and we're really excited about what the effort we put into this app. So there's a little video there. If you want to click on that link, you can see the video. It's kind of an overview of it. Last but not least, sorry, this is I've been trying for years, 3 years, I think, to get up and running. We're really, really close. Basically, kind of going back to kind of like that aristocrat study, looking at trying to figure out, is there a way to use high dose CBD as an anti-cancer agent. So actually doing up to, I think we have 400 milligrams twice a day of CBD in patients with a second line treatment for GBM, a very aggressive and lethal brain tumor. So we're hoping to get that going. It's been really hard to get the CBD approved and get an IND for that. So that's why that one's taken so long. So a lot of work we're doing, a lot of questions that remain. Again, part of the reason there's so many unanswered questions, there's so many hurdles, right? And we touched on this a little bit earlier on, but the Schedule I status, funding is a big problem. It's really hard. It's hard to get funding anywhere for research. It's really hard to get funding for medical cannabis. And an example there is we actually had a grant that we thought we secured for our pancreas study. This was a number of years ago from the one of the Pancreas Cancer Foundations. And then at the last minute, after it had been reviewed and people really liked it and they were super excited about it, they said, oh, well, we actually get some federal funding and we're not quite sure, that we can actually fund this study because it's a federally illegal product. So that was really disheartening. And I actually think most of our work actually continues to be run through with philanthropy. We have had some very generous donors, and that's, I think, a good way to get things going. And then lastly, standardization. Again, there's too many types of cannabis, right? You can't really, it's hard to do a study with a product that is really 1,000 products. So we got to figure out how to do that better. As I mentioned, I'm on the Cannabis Advisory Council for Minnesota. We're looking at a little bit of this. I think there's lots of questions, but not only in Minnesota, but beyond in terms of, again, all these products, cost. Is there more and more products, and now Minnesota's gone recreational? Now, what is the quality of those products? There's been talk forever about the DEA changing cannabis to Schedule III. That will open up many opportunities, but it has still not been done. So research must go on. Care must go on. Again, educating patients must go on. These are sort of our principles of how we try to do that. This is our email. If there's patients or providers or others that want to get a hold of us from research spending, we're happy to connect. And I'm going to stop there. Hopefully that gives us time for ample questions. But I know that was a lot to cover.
Dr. Zylla, thank you so much for your valuable insights today and sharing, research that you have conducted in the past and your current research, even through all those barriers that you are facing. So at this time, let's take some questions. Okay, so which do you recommend more for cancer patients, CBD or THC? Will either help your immune system fight the cancer?
Well, I think it's a little bit of both. I actually think THC is probably the thing that you need. I think that's really where the pain, the nausea, sleep. Oh my goodness, our patients, all of them sleep horribly. There's anxiety. There's troubles with the medications. Almost everybody who gets chemotherapy gets a very high dose of steroids, and steroids are notorious for making people really anxious and jittery and really hard to sleep. THC in particular, big help with sleep. I think more lately, my APCs have really been high on. Oh, sorry, that's not a good term. They've been enthusiastic about CBN at night. So that's another one too. But in CBD, I think it's important. CBD has sort of a synergistic effect, I think, with THC. It certainly balances some of that high. Again, our patients don't want to feel high. They want to get through their days. They want to be active. They don't want symptoms, right, from their cancer or their treatments. And so I think there's a balancing act with having that balanced product of CBD and THC. So I think they're all important. In terms of will either help your immune system fight the cancer? Well, again, back to that data I shared, the bigger risk that at least has been proposed is that these products can lower your immune system. And if they lower your immune system, well, that's certainly no good if you need your immune system to fight cancer. And it's certainly extra no good if you have things like checkpoint inhibitors and these drugs that were trying to stimulate your immune system to be stronger. So, I'm sure there's other sides of the coin. People will say, well, it's actually helping your immune system. I don't know. I think if it helps your sleep and your sleep's better and your immune system's stronger because you're sleeping better, sure. Like maybe then you could answer that THC is the one that's helping your immune system be better.
Okay, great. Thank you. Can you provide any recommendations for newly diagnosed cancer patients having great difficulty eating?
Well, again, I think anybody who's newly diagnosed, and I'm assuming this is a new cannabis naive patient that's, wanting to know about using cannabis. Again, it's starting low and going slow, right? You can't overdo it. You got to kind of layer that in. I definitely would think more about balanced products. Again, the 1-to-1 ratio type products so that they're getting a little bit of THC and a little bit of CBD. And again, not to go too far astray, but I think we're learning a little bit more about CBG. And again, I didn't get into all the different cannabinoids and terpenes, and there's so many things in the cannabis plant, right, that are important. But we're starting to realize maybe there's some certain other things that could potentially help there. And I think CBG is one that at least my nurse practitioners are running the cannabis clinic here with us are really thinking that is doing a good job there.
Got it. What unique challenges have you encountered when conducting cannabis research with cancer patients?
Well, yeah, I think I touched on it just a minute ago on the slide, but again, funding, regulatory issues, we mentioned the DEA sort of issues, standardization of dosing. Again, I don't think there's a one size fits all dose. So again, some of the studies that have been done in the past, have picked, well, we're going to give them 5 milligrams of THC, and that's the study, and that's not probably how it should be done. Again, we don't just do a pain study with opioids and say, well, you just get 5 milligrams of oxycodone and that's all you get. You titrate things. It's personalized. It's a little bit customized to the patient, their metabolism, what they need to control their symptoms. So I think that's what makes symptom management research quite difficult. But I think it's why we think we're doing it the right way. And again, especially in our cannabis pancreatic study, again, patients get to use what they need to use. We give them guidance. We don't formulate a specific hard and fast protocol. And we think that's the way to do the research, but you're going to get critique on the other side when people say, well, you didn't standardize the dose and there's no placebo and, all these kind of things. So yes, placebo will certainly be nice. That will be a challenge too, to do more placebo type studies.
Okay, got it. What advice would you offer to clinicians or researchers interested in initiating cannabis related studies in oncology?
Collaborate. It's really hard to do this like from the ground up. I think partnering and getting guidance from others is always important. Again, I posted the folks in Minnesota that I've been able to partner with, and they've just been great. We've just had a great number of ideas that have come out, different ways to do things. So I know there's some great people, and I've been able to connect with people outside of just here in New York, people in California, throughout the country. So I think that's the most important thing.
Okay, and we have one more question. Based on your experience, what do you see as the next frontier for cannabis and supportive cancer care?
Well, I think access, education are probably the two biggest ones. Again, our patients, we've seen 600 some patients just at one cancer center in the Twin Cities, Minneapolis area. There are thousands of other cancers clinics out there. There are so many people out there. And again, I think we need to do it in probably a larger, somehow standardized way. But again, it's hard because, patients get, they go to a cancer dispensary or some, shop that's selling cannabis or THC, and, they're not probably getting expert guidance, and they may have complicated medical problems. And so if you're using it for medical care, and especially our cancer patients are ultra complicated. Again, I've used examples sometimes about, well, I think it's safe. And again, I don't think this will be a problem with cannabis, but, you're on an intense chemotherapy with a narrow, what we call therapeutic index. And so that means, if you give too much of something and it metabolizes the chemotherapy differently, all of a sudden you're really, really toxic. or maybe it metabolizes the other way, and all of a sudden the chemotherapy is not effective. So, I think we have to be smart about that. Same is true with cardiovascular patients. Again, the issues with their medications and hypotension or tachycardia and all these kind of things. So I think education, having some general framework of what's safe. Again, start low, go slow kind of approach to titrate a symptom. But I think we need to do more research. Obviously, doing research trials is going to be the way you start to chip away and maybe get a little bit of people to kind of come on board. And then again, at some point, it's also maybe going to farther upstream too, and educating clinicians, not oncologists once they're in fellowship, but maybe medical students and students as they progress through, figure out where does cannabis live in the larger realm of caring for patients in medicine.
Yeah, I agree with you. All right, so thank you so much, Dr. Zylla, for today, for your insightful and valuable webinar. Thank you. So as we conclude, we'd like to remind you that today's replay will be available immediately after our presentation. It'll be on YouTube with the slides. And you can also visit cannabis.ny.gov for more information about the medical cannabis program. Please sign up for our newsletter so you can stay in touch with us. And I'd like to put up Dr. Zylla's contact information, his page with information about Dr. Zylla, his publications, his current research, and also his organization regarding cannabis research. So before we conclude this webinar, I also kindly ask you to take a few moments to complete our post-webinar survey. This will help us create better webinars and provide better content in the future. The link can also be found in the chat here. And please stay connected to us because we have a very special guest next month in July. So stay tuned, and thank you so much for joining us today, and we'll see you next time.
Thank you.